Hello, my name is Dr. Vicki Pope, and I am one of the faculty for your Advanced Health Assessment class. This PowerPoint covers the beginning components of the physical examination, the general survey, vital signs, and pain. If you have the newest edition of your textbook, it will be Chapter 4, and if you have an older edition, you will find this information in Chapter 2. The general survey is exactly like it sounds. It's what you notice when you initially walk into the exam room. As you become more skilled as advanced practice clinicians, you will automatically pick up these fine nuances when you observe the patient. This takes time and experience, so don't expect to immediately be comfortable with this skill, but know that it will become automatic in time. Two important components of the general survey are the patient's general appearance and height and weight. So let's talk a little bit more about both of these. The patient's general appearance gives you some clues as to the state of the patient's physiological and psychological well-being. The first thing to notice is whether they look overtly ill. Do they look frail, weak, cachectic? Are they alert and talking to you, or lethargic and withdrawn? What is their level of consciousness? Do they show evidence of pain, shortness of breath, anxiety? These can be evident with patients gasping or wheezing when they're breathing or coughing. Maybe they're wincing in pain or splinting a particular area of the body, or they may be diaphoretic. All of these are signs of some type of distress. Also, we want to look at the patient's skin color. Are they jaundiced? Are they cyanotic? Do they have an apparent rash on them? Any lesions that we may notice? What about their personal hygiene? Are they well-groomed? Are they disheveled? These can be signs of dementia or perhaps depression. Also, are they dressed appropriate for the weather? Somebody who's always cold, who's cold intolerant, and wearing a heavy jacket, that could be a sign of hypothyroidism, so that puts your mind in that direction. How about their facial expression? Are they making eye contact with you? It may be a cultural reason that they're not, but it also may be due to anxiety or fear. We also look at odors of the body and breath. Do they smell like alcohol? Can you smell cigarette smoke on their breath? How about the sweet smell of acetone that we see in diabetics? We can pick up some of this information just from our initial survey. Also, the position of the patient. What is their posture? How is their gait? Are they moving all their extremities well? These are all observations which can guide our management of our patient just from the initial survey. Height and weight is another important data piece. We want to look at the trend of our patient. Has their weight decreased significantly or has it increased significantly? Sometimes this can be intentional or it can be unintentional. Causes of significant weight loss could be anything from a malignancy to hyperthyroidism, depression, or simply maybe they've been dieting intentionally to lose weight. We have to talk to the patient and question them. How about if their weight has increased significantly? Are they retaining fluid? Do they have edema? And where is that obesity located? One of the things we want to do with our height and weight is calculate the patient's BMI, body mass index. So let's talk a little bit about that. We use the height and weight to determine a BMI and determine which classification of weight the patient falls into, ranging from underweight to extreme obesity. It's important to remember that there are limitations to the BMI, and sometimes a very muscular person may calculate out to have a very high BMI and be considered obese when really they're normal weight for their body habitus. But however, the BMI is a useful predictor when we combine it with waist circumference to determine patients who are at a higher risk of diabetes and cardiovascular disease. We call a collection of these risk factors the metabolic syndrome. So when we perform the health history, we are looking for information from the patient. We want them to tell us about their symptoms and what is affecting their health and their well-being. We want to ask the patient to describe their symptoms. We want to use open-ended questions and then probe further to have a full understanding. And the reason why is because terms like fatigue and feeling tired, they're very subjective. So you will need to drill down when interviewing the patient to better understand their actual symptoms. So let's review this question. A patient presents with a 6-day history of rapid weight gain. The most likely explanation is dysphagia, excessive absorption of nutrients, diabetes mellitus, or an accumulation of body fluids. Well, the answer is going to be an accumulation of body fluids, because when you have a rapid change of weight over a few days, it does suggest that the patient is retaining fluid. And you could see this perhaps with a heart failure patient who perhaps over this recent holiday ate too much salt, and from one week to the next, you can see an actual increase in weight of like 12 pounds. So that clues you in that this is most likely fluid accumulating, as their heart cannot pump that volume sufficiently to diurese them through their kidneys. And then you see the fluid back up, causing edema and fluid in the lungs and shortness of breath. So the next thing we want to go over are the vital signs that you'll be looking at in your initial evaluation of your patient. We're going to look at blood pressure, heart rate and rhythm, respiratory rate, temperature, and pain. So this slide shows you the optimal conditions for obtaining an accurate blood pressure on your patient. Now, obviously, we don't always have our patient in the optimal condition, but it is important to just remember a few things on here. You do want to palpate the brachial artery, and you do want to have the arm so that the brachial artery is at the level of the heart, and you want that patient's arm to be supported or relaxed on a table. That's really important as you're getting them ready to take their blood pressure. Now, cuff size is also very important. You want to make sure that the cuff fits your patient. If you use a cuff that is too small, you're going to get an artificially elevated blood pressure on your patient. So the width should be 40% of the upper arm circumference and the length 80% of the upper arm circumference. And you will get used to being able to put a cuff onto your patient and determine whether it is the correct size or not. Now, this slide is a very important slide, and I'm not going to read every single step to you, but I want you to review every single step, because this is not simply to get an accurate blood pressure. You don't simply put the cuff on the patient's arm, inflate it real tight, then deflate it and listen. It's really important that you position the cuff in the right position and that you palpate the radial artery and inflate the cuff until that radial pulse disappears. When you read that number, wherever that number is, you're going to add 30 millimeters of mercury to that pressure. You're going to deflate the cuff completely, wait about 30 seconds, and then you're going to inflate to that number that was 30 millimeters above where you lost your radial pulse. That will help you get an accurate blood pressure and prevent extraneous sounds from interfering with getting an accurate blood pressure. So if you're using this technique, you're unlikely to get false elevations in your blood pressure readings. So remember, please read through all these steps. They're very critical to taking an accurate blood pressure. So this slide is showing you the proper position of the cuff, and it's showing you when you inflate and release, that first sound you hear is your systolic pressure. And sometimes you may have an oscillatory gap, which is just a period of a silence before the sounds come back. When the sound comes back, you listen for the end of that sound, and that's going to be your diastolic pressure. We talked about the oscillatory gap. Sometimes you may want to get orthostatic blood pressures. So you want to see whether the blood pressure is changing significantly or dropping when the patient changes from lying down, supine, to standing up. So then when you're doing that, you want to have the patient lying down, check their blood pressure, wait 3 minutes, have the patient stand up and repeat the measurements. So if the systolic blood pressure drops more than 20 millimeters or the diastolic drops more than 10 millimeters, they are considered orthostatic. So the JNC8 guidelines say that normal blood pressure is a systolic less than 120 millimeters and a diastolic less than 80. And you can actually look up those guidelines if you want to see the different classifications. If you do get an elevated blood pressure, you do want to check it in the other arm. Some patients will just automatically be nervous. We call, possible white coat hypertension. You want to try to have the patient in a relaxed environment when you're taking their blood pressure. And sometimes you may have to have them monitoring their blood pressure outside of your office to really see if there's any significant elevation. So next we're going to talk about another vital sign that we're looking at, which is the heart rate and the rhythm. Most of the time when we're feeling for the heart rate, we're going to feel at the radial pulse. That is the most commonly used area to measure the heart. You want to count for 30 seconds and multiply it by 2, or you can count for a full 60 seconds. If you feel like that rhythm is irregular, you should count it for the full 60 seconds, but know that the only real way to know what that rhythm is to get a 12-lead EKG at that point, or a rhythm strip. When it comes to the respiratory rate, we want to observe, just like when we first walked into the room, we want to see how many breaths per minute. So we want to count the full time, and we want to see whether the respirations are regular, whether they're gasping, whether they feel like the breathing is shallow or normal. You'll get more comfortable with that as you observe more patients. Temperature is another vital sign that we want to look at. You can see there is some variation whether you're taking your temperature rectally, axillary, or tympanic. And the most common cause of an elevated temperature is usually some type of infection, although it could be caused by a drug reaction, malignancy, or some kind of autoimmune disorder. And finally, we're going to talk a little bit about pain. Pain is a very subjective symptom. It's important to take your own personal perceptions out of it and realize that what the patient feels is what the patient feels. You want to know, where is the pain? How severe is it? A lot of times we use a scale, a pain scale, to assess, maybe a 1 to 10 scale, 10 being their worst pain. What kind of treatments have they done? What type of medications have they taken? And any related illnesses or impact on their daily life. And there's different types of pain that you can go through here. I think the most important thing is to really talk to the patient and understand their perceived level of pain to look for a treatment plan that is conducive to both of you. So here we have a question. Let's look at this one. A patient comes in for a routine checkup, and you see the patient's vital signs have already been recorded. Here you have them in front of you. And what would be the most appropriate action related to this patient's vital signs? Well, when you look at it, really the only vital sign that is not normal is the blood pressure. So clearly we're going to need to address the blood pressure. And our choices here, the most obvious answer would be like we talked about earlier, to repeat the blood pressure and verify it in the patient's contralateral arm. And that is the correct answer. So this concludes our PowerPoint on the general survey. Please go back and read through your chapter, as there's a lot of really good information in there. And if you look at the end of the chapter, there's actually a section on recording your findings, which shows you how you would document the general survey, and including the vital signs and pain assessment. Thank you very much.